Thank you for joining us today. We're excited about today's panel on demographically adjusted norms. I am Dr. Lisa Drozdick, a Senior Research Director at Pearson, and I'll be co-facilitating the panel with Dr. Anne Marie Kimbell, a Senior Clinical Consultant here at Pearson. Dr. Susie Rayford, a Senior Research Director, and Dr. Jennifer Puig, Research Director, will also be monitoring the Q&A box throughout the session. This panel will be addressing some of the background on demographically adjusted norms, but will focus on the applications and future directions. Each of our panel members is an expert in this area, and we're very excited to bring them together for this discussion. At the end of the presentation, we hope you understand the context and appropriate use of demographic adjustments to norms. Our panelists today are Dr. Desiree Byrd, Dr. Antolin Llorente, Dr. Katherine Possin, Dr. Cecil Reynolds, and Dr. Larry Weiss. I will give them a few minutes to introduce themselves before we start with questions. We'll start with Dr. Byrd.
Hi, thank you for having me. Desiree Byrd, Associate Professor at the Queens College, City University of New York in the Graduate Center, also in the Department of Neurology at Mount Sinai, the Icahn School of Medicine at Mount Sinai. Very happy to be here. Thank you.
Dr. Llorente.
Thank you very much for having me. I am a professor in the Departments of Pediatrics and Psychiatry at Penn State College of Medicine in Hershey, Pennsylvania. I'm the Director of Neuropsychology, as well as the internship and fellowships in Hershey Medical Center. And I have been a consultant on the development of and reviewer for many procedures, including the RIAs, the Wechsler scales, and I'm also the co-author of the Children's Color Trails Test 1 and 2.
Dr. Possin.
Hi, good morning, everyone. I'm an associate professor at the UCSF Memory and Aging Center, a neuropsychologist by training, and my research focuses on improving the diagnosis as well as the care for people with Alzheimer's and related disorders.
Dr. Reynolds.
Hi, and thank you, everybody, for giving us your time today. I'm always flattered when anyone shows up to listen to anything I have to say. Because my wife reminds me frequently that it's just mostly interesting to me. I'm an emeritus professor of educational psychology, professor of neuroscience, and distinguished research scholar at Texas A&M University. And since leaving there, I now practice forensic neuroscience in Austin, Texas. Most of you who do know me or have heard of me probably know me as a test author. I've been very involved in developing psychological tests over the years, and in January of this year, published my 40th. I had my 40th commercially published test was released. And my first one was as a graduate student. I actually authored a test in 1978 and have kind of been at it ever since, and have been very concerned about issues of cultural bias in testing, and did my dissertation on that particular topic, and have continued to work in that area over all of these years, more years than I'm going to own up to.
All right, Dr. Weiss.
Well, good day, everyone. It's always awkward to introduce yourself. I was, before retiring into writing and consulting 3 years ago, I was Vice President of Global Research and Development for Pearson Clinical Assessment, and written, published dozens of articles on the Wechslers, and spoken on the topic in more than a dozen countries and 5 continents. Some of you, maybe 1 or 2 of you, have read the one of the 8 textbooks that I've authored or co-authored on the Wechsler series. But I think mostly I was invited to this panel because of my most recent article, which was entitled Mediators of Racial Ethnic Differences in IQ Test Scores, the Case for Environmental and Social Justice.
All right, thank you each for that. That's, as you can tell, it's a very esteemed panel. And I will turn it over to Dr. Kimbell to begin the questions.
Thank you. Good morning, everybody. Welcome. We're going to start today with just a few questions to kind of help set the stage for the remaining conversation. So the first several questions are around the development of norms and demographically adjusted norms. The first one being for Dr. Reynolds, Dr. Weiss, whoever wants to answer. What is the general purpose of norms? What are they?
Cecil, are you leaving on that one?
Yeah, okay.
I will. I had forgotten to turn my phone off. So that was, so I apologize for that. Well, you know, norms, I think, are largely misunderstood in certain ways. And I think we've gotten away a lot in clinical assessment from teaching measurement theory at the graduate level, and people don't have the understanding of norms that perhaps they had at one time. Norms are simply a reference group. That's all they are. And we have to have norms of some kind to interpret psychological test scores because of the nature of those scores. As you know, there are 4 scales of measurement: nominal, ordinal, interval, and ratio. And we all kind of got that drummed into our head as undergraduates. But the fact that we don't have ratio scores in most of psychology, it's rare to have ratio scores. We have interval scores. And interval scores only allow us to determine two real parameters that are accurately determined. One is the midpoint of a distribution of scores, and the other is the dispersion of those scores about the midpoint. That's all we can define. We can't define a 0 point. So since we can only define the midpoint of that distribution, we have to have norms as a reference point so that we can begin to attach meaning to performance on any of our measures. Simply because we don't know where 0 is. We can't find it. So in psychology, the vast majority of our instruments, we start measuring in the middle and measure outward toward the 2 ends. That's in sharp contrast to most of the physical sciences where they start measuring at 0. We don't know where 0 is on our scales. So norms have that purpose of giving us a reference point. And different norm groups give us different reference points. And so different norm groups, and I wish we'd quit calling that actually and rename them in the profession reference groups. Different reference groups simply answer different questions. There are no right or wrong norms. There are only reference groups that answer different questions. And we have to have those reference groups to refer performance on a test to that group to answer the questions in front of us.
Thank you. Okay, well then, Larry.
So the published norms, of course, are a reference group, much like any reference group. At the same time, there has been a convention in the field for quite a long time that that norms should be based on a representative sample of the population of that country. And that's true not just in the US, but in every country where these tests are adapted and translated and normed. And by representative, what we mean is that any individual difference variable that influences the score should should be represented to that same proportion in the norm group or the reference group as they are in the population at large. So if you were measuring a construct that had no gender differences, then it wouldn't necessarily be important to have 50-50 gender balance. But we know, for example, with most all cognitive constructs, that there are a few small gender differences. There are some racial ethnic differences, which are largely but not completely explained by SES. And so that's why those are the variables that we stratify and make it proportional to the population. So with that type of normative reference group, you're answering the question of where does this person stack up compared to the general population of the country.
So essentially you're saying that they're creating like a yardstick for us to be able to make an homothetic comparison of this individual in relation to this reference group. I would like to point out several things about this. One is very fascinating on what Dr. Reynolds was saying, that actually, as you go from the middle and you go towards the outside, you're actually never able to reach the end because supposedly those curves go to infinity theoretically, even though that's not the case in the objective data. But that to me has always been very fascinating. But there's a couple of issues that I would also like to point out, if I may. One of them is that then the goodness of fit between that reference group and the individual becomes a key element in that comparison. In other words, to what extent does that reference group meet certain characteristics of the individual that's being compared? And the other one is one that I have written about, how, as Dr. Weiss said, they were based on these populations, on these countries and so on, but how did we begin to select these populations? Well, I think this is where we actually made a significant error, and that is we used the United States Census. And you see the United States Census, first of all, as I've written, was not to be used by psychologists to develop psychological tests. It is the best that we have had. And we have used it historically, and everybody does, and that is great. But the US Census was not created. It was developed for other purposes, including military service in our country and appropriations of resources to the different, the 13 colonies and so on. And then over time, the census began to, unfortunately, to equate racial and ethnicity and so on, and variables that were very difficult to be able to quantify, and some don't have even a very good definition of them, such as racial composition and so on. So I think the error that we made as a profession, and this is not anybody's fault, is that we went down a rabbit hole that we should have stopped. And we have, I mean, let's face it, new standardization sample, for example, for the Wechsler scales, try to oversample certain groups of populations and so on. And Dr. Weiss can speak about that. But the point is that that is very critical in terms of this goodness of fit between the reference sample and the individual that we're comparing to against that reference sample.
If I could follow up on that, Antolin, you raised some really good points. And what I'd like to kind of take us back to on that is that it's, in my mind, the goodness of fit of the reference group to the question we're trying to answer about the individual. And we can apply multiple reference groups to a single individual and simply answer different questions. To give you an example, on the behavior assessment system for children, we provide multiple norm groups. We have combined gender norms, we have single gender norms, we have clinical norms, we have clinical norms segregated by gender. We have all of those things. Well, why do we have that? We have those to answer different questions about kids. So I don't think of it as much about the fit of the individual to the reference group as I do the fit of the question I'm trying to answer about the individual to the reference group. Let me take that example a little bit further. And I can explain, for example, how I might use those multiple reference groups. So if I want to know how Johnny's level of attention in the classroom compares to that of other children the same age in a classroom, I would use the combined gender norms for the teacher rating scale at his age And that would tell me what his level of attention is like in that setting compared to other children the same age. But I also know, for example, that maybe Johnny has a diagnosis of ADHD. So I might then follow up by looking at his profile of scores against the ADHD norms, because I also know that ADHD has high comorbidities. And I might be interested in knowing, for example, the answer to this question. How does Johnny's level of depression compare to that of other children his age who have a diagnosis of ADHD? And I can find that out by comparing Johnny's scores to a different reference group, to an ADHD sample at his age. And I can get more specific and say, and how does it compare to boys his age who have ADHD? That's a different reference group. But I'm simply answering different questions. And I use those follow-up norms to help me engage in triage, for example. Often we don't have the resources, particularly in schools, to treat everything at once that a child brings to us. And children, as you know, bring us very complex problems. So in this particular case, to go back to Johnny, maybe I see that Johnny's level of depression is a standard deviation and a half above the mean of other boys at his age with a diagnosis of ADHD. I might then discuss with his parents and the treating physician, emphasizing treatment of his depression first before we begin to emphasize treating the ADHD. Now that, you know, I may or may not make that decision. It depends on a lot of other variables like history and the impact of this on his life and things like that. But I can answer different questions with different reference groups. So I like to think, just to reiterate, more about the fit of the question I'm trying to answer to the reference group I'm using, because all tests do is answer questions. They answer questions for us that we could answer without tests, by the way, if we had sufficient time and resources. If I could follow Johnny around for 6 months every day for 8 hours, I wouldn't need any tests, but we can't do that. But tests answer questions, and it's the questions and their fit to the reference groups that I think are the most important.
Thank you. Thank you all. Thank you all. I think we covered the purpose of norms, or a large part of that question, and even why were demographically adjusted norms created. So what is their purpose? And so let's talk about maybe then how those variables have been selected historically for adjusting norms for the demographic adjustments.
Well, I'd like to maybe just back that up a half a step there and talk about why we decided to create demographically adjustment norms for the Weiss score and WIM score in particular. Well, let me preface this by saying that in my role at Pearson, I was fortunate to be able to have a very broad overview of different subparts of the field, because these tests and these instruments are used by school psychologists and clinical psychologists and neuropsychologists in different ways and in different settings for different purposes. And one of the things that always amazed me was how isolated many psychologists were in their own part of the subfield, and unaware of really how different parts of the field practice and how they use the same instrument differently. And with the Weiss and WIMs in particular, we were very aware that there was a small but critical part of the field called forensic neuropsychology that used demographically corrected, as they were called at that time, demographically corrected scores. And they used it for a specific purpose, a specific use case, and that is, and forgive me if you are a neuropsychologist, this is so obvious to you, but I think we have a broad audience. But in those use cases, you have an adult usually who has suffered some type of injury or illness, and they are in litigation with some other group for having caused that and to receive damages. And so the psychologist has to show that this person has some type of cognitive impairment due to the injury. Now, obviously, the best way to do that is if you had a pre-test score and then a post-test scores, but you almost never have that. So they use demographically adjusted scores as a way of estimating what this person's level of functioning might have been given their race, their ethnicity, their age, their gender, and their education level. It's a gross sort of approach to it, but it's what people do in that part of the field. And they were relying on journal articles that had published demographically corrected scores, such as Bob Heaton's, which were very, very good and widely used. But we realized that we had a lot more data, and so that we could get more accurate demographically adjusted scores in the tails. And as we talked about that, we were very concerned about those demographically corrected scores being picked up and used for other purposes beyond what they were originally intended. And so what we ultimately decided to do to kind of put some guardrails on that is, number one, is we didn't provide those corrected scores in the published official manual. We did them in a textbook that Jim Holdnack was senior author in with Lisa and myself and Grant Iverson. The second thing that we did was to put them on a T-score metric rather than an IQ score metric. So the mean of the demographically adjusted scores is 50 with a standard deviation of 10. And we did that on purpose so that no one could ever confuse the adjusted score with the so-called official normative score. The other thing we did is made sure that we didn't call them corrected scores, because correction implies that there's an error that has to be fixed, and that's not the case. And then of course we didn't provide them for other types of tests where that weren't commonly used in this forensic neuropsych setting. So now, I'm going back quite a few years, but I wanted people to sort of understand where they came from, what their original purpose was, and what the thinking was at that time, and then we can kind of go from there.
Yes, thank you. I'm going to hand over to Lisa now to talk further through the application section.
Yeah, we're going to pull all our panelists in now. So thanks for the background information. And this next group is, can you, Dr. Byrd and Dr. Possin, what situations do you see that are appropriate for the use of these demographic adjustments, and maybe some that might be inappropriate for these uses?
I really like Dr. Reynolds' discussion of the reference group, and you have to choose the right reference group to ask the question that you want to answer when you get the right answer for your question. And I think that, sometimes we do need to use demographically corrected norms to answer the question of whether somebody has experienced a brain injury or disease. An example of this, where I think it's important, is sometimes where I'm evaluating a patient who has immigrated to this country from somewhere else, and they're from a disadvantaged background. Well, if I were to use the normative data that's even if census-based, is predominantly white and more advantaged and more educated than this individual sitting in front of me, then I might over-identify a new cognitive disorder in that individual. And so it's really important that I use a reference group. But what reference group to use? What if I only have norms at my disposal for either a predominantly white census-based reference group? Maybe I also have some Latino norms that I can access, but maybe this person is from the Philippines, and maybe they're not Latino, but then maybe they're a recent immigrant I might want to choose the reference group. I might try both reference groups and to try to get to the best answer. And I think what we have, when it's not, one thing that's not appropriate when using these norms is to rely on a simple plug and play formula to diagnose patients. That can be very dangerous. And so an example of that I recently wrote a viewpoint about is the case of the NFL players. So in their landmark settlement agreement, an NFL player who has experienced repeated impacts to the head and develops dementia, if they're diagnosed with dementia under the settlement agreement, they can get a substantial monetary award. Well, the NFL has been accused of requiring the neuropsychologists to use adjustments for being Black. So they're not giving those neuropsychologists the flexibility to determine which reference group is most important for determining if that person in front of them has dementia. And of course, we know that diagnosing dementia is not just about your scores on tests anyway. You have to consider other clinical information. But they're accused of requiring those neuropsychologists to follow a plug and play formula with adjustments for being Black. And in doing so, it sets a different standard, a different benchmark for receiving those monetary rewards. In other words, if you're a retired Black player, you have to score lower on the same tests than the retired white player to get the same monetary award. So that's an example of something dangerous that has happened as a result of these types of norms.
And Katherine,
Yeah, and
there are other examples of that too.
To piggyback, and thank you for bringing the conversation here. I'm glad you mentioned the word harm, Kate, because I don't know that it's appropriate to dig too deep into like how to use the best available demographically adjusted reference groups currently without some attention to the harm that has been done historically with psychological testing and persons with marginalized identities, especially Black and Brown people. And so while the discussion regarding which specific referral questions might be most appropriate for the available reference groups, I think it's important to also remind the listeners and ourselves to critically evaluate like the overall structure and the process. And Pearson is perfectly suited as one of the premier psychological testing companies. I'm very happy that you're sponsoring this conversation because there are theoretical considerations that I think clinicians, educators, of course, I'm both, and scientists have to contend with in order to ensure that more harm is not being done, and that we move toward equity. And I know the conversation will get there, but I just wanted to offer that reminder. Thanks.
I like that we are switching to the term reference groups instead of norm groups. So we are having a lasting impact just right here. So thank you both.
I started making that argument in 2014, and I haven't been getting a great deal of traction. But maybe this will help.
Can we go a little deeper for our audience? And I know there's been a couple examples brought up about how these demographically adjusted norms can help inform interpretation so that we aren't doing additional harm, but that we're continuing to provide good care across populations.
So one of the things to keep in mind, just to preface that part of the discussion, is that when you, if you have a high ability person and you demographically adjust their score, that score will come down. If you have a low ability person and you demographically adjust that score will go up. And the further either of those people are away from the mean, the more the score gets adjusted. And the adjustments are based on group characteristics of the group that they belong to, not on any individual difference variable. And
one of the things that I I wanted to note is that the issue of harm is often contextual. And I think something that we have to struggle with, and I would be very interested in other panel members' views on this. If you're using demographically adjusted norms in the context of referrals that might lead you to a diagnosis of intellectual disability. In the public schools, we know that African-American children, and more so boys than girls, are disproportionately identified as having intellectual disability. And that the use of demographically adjusted norms might remedy that disproportionality. So that might prevent harm. On the other hand, my current practice is exclusively forensic neuroscience, and about 80% of my practice is death penalty defense. And as you know, if a person is diagnosed as intellectually disabled, they are barred from execution. So I run into the instances with African-American defendants where we arrive at a diagnosis of intellectual disability based on the large-scale population proportionate norms, and the state hires a psychologist who comes in and says, no, those norms have to be demographically adjusted. This person does not have intellectual disability and therefore is eligible to be killed by the state for their crime. And we're arguing, no, they do have intellectual disability and they're not eligible to be executed for their crime. So here we have competing outcomes, if you will, as to what is harm and what isn't, and the context of those norms. And even looking at adaptive behavior, looking at academic achievement, looking at all the things that go into getting to that diagnosis of intellectual disability. In one context, it prevents harm, and in another context, the same process induces harm. And I don't mind saying I'm very conflicted over that. And when do we do what?
And
I think it's a very complex question.
And I want to also come from a different perspective to this issue, and that is, I think if we continue to depend on some of these norms, we are absolving ourselves of the responsibility of studying why is it that these differences are occurring and studying those differences better, number one. Number two, it absolves us from creating better tests and procedures that can account for these differences. And I think that's a very important issue that needs to be addressed. I would like to show the panel, if I may, I mean the participants, if I may, a slide from research that was done with the Weiss. I'm not sure, let's see if I can do this. I hope that everybody can see this. What this is data that Pearson was kind enough to share with Josette Harris, who is in Colorado, I think still, and I, looking at the standardization sample. This one, I'm sorry, was with the Weiss 4, by the way. Looking at the differences, and I apologize for these, again, for this qualitative descriptors, Hispanic versus white, but that's what the census uses. So let's bar that. So you can see the discrepancies in the scores here that emerged during that standardization sample. Now, look, when we correct for what I call the usual suspects, equating for age, gender, parents in the household, parental education level, if you recall and read the manual, You realize that when there are two parents, then it's kind of an averaging of the education of both parents. When there's one parent, there's only one educational level, and the US region. And you can see how the discrepancies now become much smaller. So you can see from that graph. So then the question was, which very impressive that we were able to do this, because during the development of the test, a questionnaire was included to examine what was the language spoken in the home by these children. And so now you can see that the difference really was created of the language spoken in the home. And when Spanish was the language spoken in the home, then those children didn't do as well on most of the indexes on the Wechsler scale, is fourth edition. You can see, however, that the discrepancy now is only between the Hispanic children who speak English in the home and the quote Weiss sample of about 1 point in the standardization sample. So somehow that is a powerful factor. My point is, I think, that these are the kinds of issues that we must examine and look into as we develop tests to empirically investigate these variables that can account for these differences and therefore get rid of them. I'm going to see if I can get out of here. Thank you so much.
Well, I'm going to let Dr. Possin follow up on that. I know that there are a lot of suggestions of variables in her article, and Dr. Byrd as well. I know you've published a few things on that as well, that might be ways to look at some of these differences and get at why are there differences. I think that's a very powerful question.
Yeah, I couldn't agree more. And thank you for sharing those slides. You know, when the field started using race and ethnicity adjustments, it was a Band-Aid to a problem. But I think we're at the point now where we need a more precision medicine approach to determining the appropriate reference for the patient sitting in front of you. And I don't actually know what the best approach is, but I think the next step is to collect large amounts of data on cognitive tests that are appropriate cognitive tests. I think if you haven't read Desiree Byrd's recent paper on this, you should. So really appropriate cognitive tests, large samples of data, and measures of social determinants of health. So we just heard about parental education being a really important predictor. You know, language spoken in the home or familiarity with English, something like that. So there's a whole host of variables I think we need to look at. We may come up with some sort of composite scores that seem to be really important, or it may be individual variables. And also what you adjust for, I'm going to stop using correct. I'm learning great terminology during this session. What you adjust for may depend on the question that you're trying to answer, of course. Here's an example. So since I work mostly with Alzheimer's and related disorders, I'm trying to determine if the patient sitting in front of me has developed a new neurodegenerative disease on top of their whole lifetime of social experience. Well, that lifetime of social experience can both impact baseline cognitive test scores. Maybe they're less familiar with the English language, for example, or due to exposure to early life education. But also some of those factors can also impact risk for neurodegenerative disease. So it is very complicated. And I think we need these studies to be longitudinal so we can tease apart the impacts of social determinants of health, both on baseline cognition as well as risk for disease. So we can work towards a precision medicine approach to reference standards. I think a lot more work needs to be done. We don't have an ideal approach that's ready today.
Absolutely not. And while it's reasonable to consider the best reference sample, it's still a Band-Aid, right? If psychological tests were truly properly constructed, there wouldn't be a need for so many adjustments, especially not for identity-based factors, perhaps for education, as that is an acquired attribute, so to say, in terms of experiences. And so in my opinion, we need support. And by support, I'm thinking government funding, maybe private funding, to go back to the drawing board. We're speaking about reference groups when we should also be considering construct validity, ecological validity. There's more to it than just that. I know reference groups get us to the end goal right now, but if we think beyond just right now in terms of rendering a diagnosis that can help, and I'm always in the position of or biasing, so to say, myself towards helping and going away from harm, thinking about Cecil's question. And that's just, that dilemma is one of America and, where we personally align our values and our interpretation, I think, of help and harm. But I encourage a return to basic psychometrics and perhaps a reconsideration of psychological assessment. So thank you, Antolin, for kind of guiding us there. So Kate, still better Band-Aids really is where we're going with this. When we talk about this, what should we adjust for this? Or what about that? They're better Band-Aids.
Yeah, and when you talk about adjustments based on race or ethnicity, there's an assumption that the race or ethnicity has caused the difference, and that's not necessarily the case. And really, I don't believe it is the case. And if you look at the data that I published in the article I talked about on the case for social and environmental justice and these differences, what we saw is that when you control for parent education and other factors like that, gender, region of the country, that the racial ethnic differences between Latinx and white disappear. That completely disappear in terms of, if you look at R square and the variance accounted for, goes to 0. For the black-white comparisons, they reduce very, very substantially. And they do so in a consistent way where these other variables account for the black-white differences much more so for younger children than for teenagers, and more so for teenagers than older adults or middle-aged adults, and even more for middle-aged adults than older adults. So what you see is generational shifts in these scores coming closer together over time, but still not there. And so, some people would argue that race and ethnicity are really just proxy variables for these other factors that are actually causing the difference. And we should be looking at what those other factors are. And I think that one of the arguments that I try to make is that no one is born with a specific IQ score, right? None of us believe that. You're born with a range of potential. And the extent to which that potential is actualized depends upon environmental inputs, and the right environmental inputs at the right times during the course of cognitive development. Now, that is probably not anything that too many people would disagree with, but then you layer that with this intersectionality of race, ethnicity, and socioeconomic status. And you see that the environment, the cognitive environment, is different for different groups of children in terms of a cognitively enriched environment versus a cognitively impoverished environment, which differentially facilitates or impedes the course of cognitive development over time. So to me, adjusting for race and ethnicity is really just a proxy, and we have to go deeper.
And Mary, it even goes even earlier. I published a study some years ago where we looked at about 5 million live births in the United States, and we had about 88 different variables we were using to predict outcomes later in life, all of which were prenatal variables and immediate birth variables. And we came up with a basket variable, I call it. And I think that's kind of what when you talk about a proxy variable, race and ethnicity kind of represent a whole basket of things. And we're not entirely sure what all's in that basket. But we came up, one of the things that we found was that prenatal care and the mother's behavior during pregnancy was substantially predictive. Things like continuing to smoke once they found out they were pregnant, continuing to drink, continuing to use drugs of various sorts, things like that. And for many of those individuals, it had to do with valuing that pregnancy and how they took care of themselves during that critical time when they were carrying that infant. It also had to do with access to resources during pregnancy. And so it starts even earlier. It starts when the mother finds out that there's a pregnancy. And from then on, the environment and the ecology are influencing that outcome. And it influences it not only in terms of future IQ, but behavioral variables as well. There are a variety of things like impulse control and attention that are associated as well to many of those prenatal variables. And
Dr. Byrd, go ahead.
I just feel like we're getting too far away from so right. What else is in that basket is racism. And when people show up for a psychological evaluation and they know that the psychological testing industry historically has been used to denigrate their people, they are bringing that knowledge to the testing session as well. So how about psychology change the narrative so that when examinees arrive for evaluation, they don't have to contend with stereotype threat, right? It shouldn't be that we have to like find explanations for differences if we're not addressing the racism that's behind even those differences. So, you know, I just want to bring us back to, I guess, where we're going with psychological assessment and how we can do better and move towards equity. I forgot if this is an hour and a half, but because we're getting into things that could take us a long time to talk about.
So one of I wanted to use a perfect example back to what Dr. Weiss was saying. Why is it that these proxy variables, as the way we're collecting them today, are not as good? Well, I'm going to give you an example. When a psychological test, for example, say for children, since there was a question in the Q&A talking about, they wanted to hear more about children. So psychological test uses parental education, for example, as a proxy for some of these variables. It doesn't talk about the quality of that education. And there's tremendous differences in that quality. And that variable then is embedded in how many years of education the person had. So again, we have to understand better these, quote, proxy variables that we're using to examine them in greater detail to see where are these differences coming from.
And I just to bring us back, to the norm test, the questions, because I do think I agree the norms are just one piece of this gigantic puzzle, and as we kind of unwrap it, here's another piece of the puzzle, and here's another piece of the puzzle, and you know, the interactions in the testing session, the pieces of the test, the pieces of the norm, who's the reference sample, all of that plays into that. So we did get quite a few questions about the application of these across types of tests. I know we focused, I think, on behavior and on cognitive, but what about personality tests or neuropsych tests as well were brought up? And then specifically a few questions about what about uses in children? Because they are probably the highest tested population right now because of their location in the school setting. Any thoughts on that?
Yeah, that's an embarrassment to me that the psychometrics and the application of testing is more refined. I'm a neuropsychologist. I work more with adults and geriatrics. It's more refined in those populations than for children. You said the key thing, kids are the most tested group, but yet demographically adjusted reference groups, careful studies of psychometrics. I published a paper on this like in 2007. It's been more than 10 years ago. And I was astonished to learn how dry that environment was in terms of critical analysis, updated, studies and so forth. And so that's a reflection. That's something that should be a charge to graduate schools. I wish the NIH would pick it up, right? So the factors that we talk about, the areas in need of most attention, the investigators need money to do the work. And so I'm embarrassed that the pediatric neuropsychology in particular is lacking in comparison to the state of the field in adults and geriatrics. And I'll give some time for someone else to respond.
Well, I think we have to. There's no easy answers here. That we don't have any perfect tests. There's certainly have to state that, and the reference groups are composed according to convention. We can relook at how they're composed, but at the same time, and we need to do those things. At the same time, we also need to ask ourselves of, is changing the test going to change what exists in reality? And we all have heard a lot over the last year about the social and economic inequalities that persist between racial ethnic groups within the United States. And we hear a lot about that in terms of the legal environment, the policing environment, but also in terms of education, and a little bit closer and even more closer to what we're talking about in terms of healthcare and prenatal care and well baby checks and so on and so forth. And I think that because of that intersectionality of social inequality and racial ethnic group that exists due to systemic racism, that children are not raised in the same cognitive environment. They're not don't have the same opportunities for enriched, cognitively stimulating environments that enhance neurocognitive development. And that is, well, I'll just leave it at that for right now and see if I can get some responses.
Yeah, I'm sorry, go ahead.
Oh, well, I just, I have a couple of reactions to all of that. One is that I agree with Desiree that we need to do better, and I think we can do better. I think it was Maya Angelou who advised us that when you know better, you do better, right? And we have a big learning curve, and I think there's a lot of struggles with how to cope with these issues and what to do. But I also want to point out that there are things that psychological tests, as they're currently configured, do that are quite beneficial. Actually, one of the things that we found some years ago, actually 21 years ago, I think, with my colleague on the BASC, Randy Camphouse, had a very large grant from CDC to look at screening children for certain mental health issues. And one of the outgrowths of that was we developed a very rapid behavioral and emotional screener that's objectively scored. And one of the things that we found was that using objective screening methods, which are a form of psychological test, a behavior rating scale, greatly reduced disproportionality in the referral of boys of color for programs for the emotionally disturbed, compared to the subjective judgment of teachers. So we find actually greater equity in using objective data in that context. That was also consistent with another finding that that we had. I chaired the American Psychological Association Task Force on Zero Tolerance Policies. And one of my task force members was Sandra Graham, and she was very, very instructful to us and pointed us to some very good research in that context that showed that boys of color in particular were disproportionately suspended under zero tolerance policies for the same behaviors that could be exhibited by basically what were white middle class kids, because the teachers were misinterpreting the intent and purpose of those behaviors because of their lack of cultural knowledge. So, and we took a very strong stance against zero tolerance policies for that and many other reasons. They're mindless abrogation of adult responsibility to determine the purpose of behaviors and what's behind them. But that aside, the use of objective data in these contexts does have benefits, but unquestionably we can do this better. And it is a struggle to do it better, and we don't know the answers to all those questions. But I'm not ready to throw the baby out with the bathwater. I want to continue to work toward improving what we do and improving the questions we ask and improving how we get the answers to those and their relevance to the person's life. Because in the end, it's all about facilitating children's development. If we're not doing this to facilitate their positive development, we shouldn't be doing it.
I want to also address another issue that was brought up in the Q&As. I think somebody asked, how is it that technology, I recommend that they, there's data about that. So for example, some of our patients had never sat in front of a computer, as Dr. Catherine, I'm sorry, I don't know how to pronounce your last name.
It's okay.
Thank you, I appreciate it. I didn't want to destroy your last name, but in any way, as she mentioned, you know, it is very critical that that variable be examined because many, say, immigrants are affected by the lack of access and knowledge of computerized methods or even having a computer. So technology also affects the performance of some of these individuals. The other that was also brought up by another, I think a graduate student made a comment saying, you know, what about literacy? I recommend that people read the work of Kress, K-R-E-S-S, talking about modern definitions of literacy, which no longer is just whether you can read or write. So these are all very important factors that are built into these proxy variables that we are talking about that we need to understand better, and that can be part of procedures. But I want to also now step back, I don't know, maybe 50 years or even more so, because I think, as I mentioned earlier, where we made an error in going the rabbit hole of using a nomothetic approach. Luria, for example, would never have used a nomothetic approach and never used a nomothetic approach, but instead he used a serial analysis of the patients. In fact, if you read his books, you can see little pictures of day after days after day that he went to see the patients and even giving them the same exact test just to see the progression of the patients in a rehabilitation hospital. So I'm going to pose a question because I don't have an answer. So instead, I'm going to pose the question, is it that maybe even we need to change the way we look at neuropsychological assessments and need to be thinking about the future in terms of serial assessment and to think about maybe more limited assessment methods. And Dr. Reynolds during the pre-meeting or the presentation was talking about some data that has been coming along and I'm very aware of this, that screening measures sometimes are less necessary to have these kinds of adjustments and so on. Maybe he can talk about a little bit more about that. But my point is, we need to rethink how we assess our patients, starting from the very beginning in the arguments that were being made in the area of assessments between using an approach of comparing, or as Dr. Reynolds also put it on, a specific answering questions about a patient rather than thinking of, trying to answer multiple questions. And then the final thing I want to say is something that was also made in the Q&A. Look, if you're an astronomer and you want to look at Alpha Centauri, you have to use a specific type of telescope that you're not going to use if you're just looking at the surface of the moon. Psychological procedures are tools. It's incumbent upon the professional to examine how he or she is looking at the patient in relation to these reference norms, and what kind of questions the reference norms can answer about the patient on the basis of the tool that he or she is using.
And
hold on,
If
I'm
I-
going to let Dr. Byrd and Dr. Possin have been holding for a bit.
So I feel like this has morphed into a number of things. And I'm mindful of the students. I'm an educator first, and I would imagine there are a lot of students on the call. And so as a reminder, we're talking about psychological constructs. So what neurocognitive abilities are, what intelligence is what the measurer says it is. And so we have to kind of ground ourselves, I think, right there. Also, it's important to name that a lot of our discussion has gotten into like, where's the deficit essentially in the backgrounds of people with different scores. And that's really, really dicey, because we're measuring abilities that wherein the people who developed the test weren't considering the abilities that are very assistive and important in other communities and things. So I'm not sure how universal even the constructs are, and just wanted to bring that out. But I would hope in the time that we have left that we talk about other demographic considerations as well, because I feel like this has gotten into like a race differences conversation. Some very important points have been brought up, but this is about more than that. And, so I just wanted to offer that.
Thank you. Dr. Possin?
Oh, goodness.
A lot of stuff flew by there.
Yeah, absolutely. We need to look at other things too. So for example, the impacts of sex can differ depending on age and culture. There's cultural effects associated with sex or gender as well. So we have to look at interactions between these variables. But as I think a lot of the listeners might be very confused about what to do now. We're hearing such fantastic ideas about where this field needs to go. But what do you do now with these imperfect tools? Should you just throw up your hands and give up? And I think we've gotten some great suggestions about what to do during this panel. But I want to really underscore something I heard Dr. Byrd say earlier, which was, going away from harm. So when in doubt about what to do with the person sitting in front of you, with these imperfect tools, choose the path that goes away from harm. Too often our tools have gone towards harm. There's a history of these types of tests being used to legitimize social hierarchies. Oh, why do people who have less education score lower on tests? Well, it's because they're less intelligent, and that's why they didn't get as much education. These things were used to legitimize these social hierarchies, to explain why people were poor. And it continues today. We heard some really important examples during this panel of the harm that can result from the use of these practices. So think about what is best for this person, what's appropriate, but when there's ambiguity because of the weaknesses of our current tools, choose the path that goes away from harm.
Yeah, if I could comment on that as well, I think ultimately all of this resolves to a question of validity. And validity is not a characteristic of a test. It's not a characteristic of a score. Validity is regarded in the measurement field now as a characteristic of your interpretation of the person's performance on the test. And validity then is always contextual. And I think that captures what a number of folks have been saying, and particularly to go back to Antolin's comments about changing and not using a nomothetic approach. Well, that too is contextual. In a rehab hospital with someone who had a significant acute TBI, my context is very different than if I'm evaluating someone in the context of a lawsuit over personal injury, or if I'm evaluating a child to determine their eligibility for special services in the schools. The contexts are different, and the interpretations I'm going to make of my test scores are going to be affected by that context. But even before I get there, my choice of instruments and techniques and how I approach the problem and deciding what questions I need to answer to facilitate this person's development have to be addressed. And it's at that point that I choose instruments and techniques to fit that context. And then I have to interpret them in that context, given the full breadth of knowledge that I have about this person and the context of their life. The blind interpretation of test scores has no place in practice. We need to have a great deal of knowledge about the individual and the context of their life and the context of the referral and the context of the questions we're attempting to address in order to make accurate interpretations. And that's what validity is. Validity reflects the accuracy of our interpretations of those test scores.
So we have about 20 minutes left, and I'd like to leave a little time for some of the Q&A. I know some of you guys have been watching the Q&A box, but that is way too much info coming across over there for you guys to keep up. And so where would you like to see demographic adjustments, and not just, as Dr. Byrd's pointed out, demographic adjustments related to race and ethnicity, but maybe to other factors that we've not considered, or getting at the constructs that are being measured and making sure that the constructs are comprehensive across groups as well. So what are some suggestions that you have for, where are we going with these types of norms, or where should we be going? So, and what would you find useful with these?
Well, as we've done with the BAS since the 1980s when we conceptualized it, we've always had multiple reference groups. And I like the idea of extending those multiple reference groups, provided that we educate students who are coming up and existing clinicians about this whole concept of thinking about them as reference groups and framing the questions we're attempting to answer, and realize that we get answers to different questions with these different reference groups, and defining the reference groups that are necessary for the context of the different types of evaluations that we do. And to the extent that students are well educated about that, and that we can enhance the education of existing clinicians about their need for knowledge about the person that they're seeing and about the context of that person's life now and the contextual history of their life, we can ask better questions, and we can approach those questions with better techniques that are more carefully aligned to the answers that we need to get in order to facilitate their development.
Yeah, Dr. Reynolds, I like that. So the provision of more and better characterized reference groups, a shift in the attention to the term reference, and this whole idea of goodness of fit between the referral question and the reference group. I'd like to see some fundraising for more science. I'd like to see some creative, the invitation for creative solutions. I'm sure there's some we haven't considered yet, probably sitting in the minds or the dissertations of students on this call. And then perhaps what about some literacy-based reference groups? Also, what about reference groups where people of different education levels, ethnic groups, genders are equally represented in opposition to reflective of the proportionality in the United States at any given time? What if every single factor that's important, even when it comes to language, right? We haven't talked about bilingualism and the degree to which what we know about people who speak more than one language and the need for reference groups for them and how to characterize that a very important factor. But what if, to the degree that we represented everyone equally and say, here's a massive reference group. That would be very helpful too. So those are some ideas off the top of my head.
All right. Any additional, Dr. Llorente?
The research that we can do can be built onto established large studies that are going on that are answering other questions. So for, as an example, there's a big study I work on in Latin America where we're going to collect data on 6,000 people across 6 countries who are healthy older adults or have Alzheimer's or other neurodegenerative diseases. Well, by tacking on a comprehensive social determinants of health survey, as well as using what we think are some really exciting neuropsychological tests that are appropriate across countries, we'll be able to begin to answer that. So that's a study that's, largely funded to answer other questions besides reference group adjustments, but that in fact, that reference group adjustments is something that I'm really excited about doing with the study, but it wasn't even mentioned in any of the grant applications. But it's something that we can do because we're just able to add these on. So whenever we see these large cohort studies that are measuring cognition, it's a chance for us to weigh in and advocate for adding comprehensive measurement of social determinants of health, as well as really good cognitive tools. And so it's not that expensive if it's an add-on to one of these ongoing studies to get the data. And I'll also just wanted to comment on, I think there's a question in the chat and it came up about technology. And, in my work, I do a lot of work with tablet-based cognitive assessments. And we find that even people who have never used a smartphone or tablet computer or any kind of computer can complete these reliably if the stimuli are approachable, if the response format is very simple. We wouldn't ask them to swipe, for example, but just simple touching of responses. And I think we're testing this out, it can be more approachable to some people with lower literacy than, say, paper and pencil based tests. Somebody who only has 3 years of education and lives in rural Peru might actually be more comfortable with a tablet-based interface if it's designed appropriately than with a pencil and paper test. Now, of course, another alternative, there are tests where you're, working with everyday objects. And so that might be possibly even better for somebody with very low education and limited literacy. So that's something we want to test out. But at the same time, that kind of testing requires someone who's very highly trained. And I think we need to, as we think about the future, also have tests that can be used by people who maybe are not neuropsychologists, because we don't have neuropsychologists in many parts of the world, even many parts of this country. And so while ideally we have a well-trained neuropsychologist doing every assessment, the reality is most people don't get any cognitive assessment who needs one. And if they do, it's going to be by someone with limited training. So we do need some tools that are easier to use in a variety of everyday clinical situations.
Dr. Llorente or Dr. Weiss, anything to add?
Oh, there's so many directions to potentially go with it. And, you know, this is a bit of a lark, but I remember Jane Mercer, a researcher in the 70s, who provided demographically adjusted scores for the old WISC-R. And she had adjustments for just about everything that you can think of, including the number of children in the home, what your birth order was, whether you're a parent, you know, you were raised by a single mother, their education level, on and on and on. And it was like, I think 13 different adjustments. And people didn't really use it because they got frustrated with it, and they found out that just about everyone they tested turned out to be average. Well, of course, if you get a reference group of everyone who's exactly like that person, then the person you test is going to be average. And so that's a bit silly, but kind of pointing out the extreme of where it can go with trying to find a reference group that is perfectly fit or ideally suited to the patient in front of you. And if you and when you adjust for education, you know, education we know is highly correlated with cognitive ability, right? So when you adjust for education, in a way, somehow removing part of the influence of intelligence on intelligence. And we know that index scores are less correlated among themselves after adjustment than before. And so you're more likely to have highly discrepant index scores after adjustment. And if you're using discrepancies in index scores to assist in the diagnosis of disability, then you're going to get more of that. So there's the unintended consequences and need to be fully thought through from every perspective.
I just wanted to say that I think these questions are also empirical. I think we, as psychologists, need to move more towards empirical work. And so, you know, for example, Pearson has a tremendous amount of data sets that could be examined to find out perhaps what is it that accounts for variances in some of these procedures and so on that can be then placed, you know, as these are selected. But I also want to say something else, going back to the practice, the actual practice when we do this. This also happens in other areas. For example, if you're a neuropsychologist and you administer a Boston naming test to a 17-year-old, there are no norms. Yet we sometimes want to administer that procedure to investigate a person's responses because it can be related to a specific difficulties. So what do? Well, it goes back to what Dr. Reynolds was saying, you know, sometimes it's good to have different norms. So for example, I will compare the data with younger individuals and I will compare the data with older individuals because I don't have my exact reference group. And then try to make a judgment. Indirectly, what I'm trying to say is that you cannot throw the water with the baby. And the thought process of the clinician and what the clinician is doing with these tools is just as critical. Because again, Dr. Reynolds is correct. This is not, the test has no validity in and of itself. The test is an inanimate object. The inferences that a clinician derives from a test, that's where the validity has. And so therefore the clinician is the most important equation in the use of these tools.
All right, I'm going to ask one final question and then we'll wrap up. This has been fascinating, went down some roads I wasn't quite sure we would go down, but I want to end with, we had a question from a member. What do you guys think about open source normative databases? There are several grant funded studies right now to collect large groups of data on various populations for, you know, on some of our major tests that we use across. How do what are your thoughts on those types of databases?
I don't know a lot about the screening procedures, and I would imagine that they are available, but trusting that they are similar to what's done with normative reference data that is not available in open source through open source mechanisms, that's exciting. That's a fabulous, well, probably not good news for Pearson, right? Because I did want to introduce the idea of access, that as more refined demographically adjusted reference groups and data become available, currently it's accessible if you can afford it, right? It's an add-on to most tests. And so that's a conversation, if we're being fair, to be had here about the clinicians' access to the best possible data. So I'm in favor of open access data. Yeah.
I see a lot of head nodding. Anyone else thoughts?
Well, to me, it really depends on the integrity of the data that's being added to it. It's not just open access in that sense. It opens access to people to add to the database if it's really going to be useful. But we need some way to assure the integrity of the data that's being added. And I think there are ways to deal with that. I don't think we've given enough thought to it, but there are ways to deal with that. And there are ways to deal with that in corporations that profit from tests like Pearson. I think there are ways to do that to allow continuous updating of the norms through open access, but control of scoring algorithms and things like that. So it can be made to work in a commercial environment to everybody's benefit, and ultimately could reduce costs, which to Pearson and companies like Pearson, and therefore reduce costs to the clinicians as well. So I think some careful thought about that and some creative ways of doing that can work to everyone's benefit. It can work to the company's benefit, the clinician's benefit, and ultimately to the patient's benefit. If it doesn't benefit the patient, we shouldn't do it. But I think it can, and I can envision ways to deal with that work for everybody. A win-win-win solution to what we're referring to as open access.
All right. Any final words from panel members? And maybe that's the can I shouldn't open, but all right. I greatly appreciate this panel. I know I learned a lot today. I think my takeaways are definitely context. I think that's what everybody should be doing anyway, but sometimes it helps to be reminded context, that both in and out of the testing session, in our discussions when we're in our training. Reference group is another thing that I think we can take away from this meeting. And a shift from asking maybe why the differences for looking at, for looking at the causal points, not just the proxy variables that we use, but really look at the underlying issues. I think is definitely a move forward, but also looking at our tools. I think we are moving forward and we keep moving forward, but maybe as this is the time to pull in new voices and new thoughts that we haven't maybe had, especially, this year where a lot of voices were very quiet, unless you were reaching out. It was a hard year, but I think this is exciting. I think this series is going to be continuing this equity series of webinars. I think there were several things that came up today that might end up as a future webinar. And I'm very excited to see how many students were also in attendance. There was quite a few that identified, especially Dr. Byrd, after you said you were a trainer of students, a lot of folks started identifying themselves as students. So that's always exciting to hear that students are in the audience, because they are going to be using these tools and the future tools, and their feedback is huge. So thank you for this. I just can't even, I'm excited to be in the web room with this group. It's a very a great group of people. So I appreciate everybody's feedback and input. And we are going to keep the Q&A open for a little bit so that I know some folks were trying to pay attention and talk. But if you want to kind of peek through the Q&A, now might be a good time. There are a lot of really good questions that we just would not have had time to answer in here. But for our audience members, thank you so much. If you have a question that you want to direct to a particular panel member or that didn't get answered today, please, when the session closes, enter the question so that it will get to those folks in that. And
Lisa,
Sherry back, oh, sorry.
could someone capture all those questions and send them to us so we can look at them?
I'm going to have to ask Sherry to address that.
I haven't looked at them because I can't listen to everybody and concentrate and read those at the same time. But I'd love to see what questions were raised.
Sherry, if you are, I don't know the capabilities of the system. Can you answer that question?
Lisa, I think we can share the de-identified questions after.
Yeah.
Okay. Yeah.
Yeah, I don't need to know who asked them, but I'd like to know what they were.
Yes, we can send those out to everyone.
Great, thank you.
Okay.
I'd just like to thank Lisa, who's only pretending to be the moderator because she could actually be on the panel as one of the co-authors of that Advanced Clinical Solutions book that actually first published the demographic adjusted norms for Weiss and WIMS.
And Sherry, I will let you close this. Thank you.
Thank you.
Well, I'd like to thank everyone for your participation in our webinar today. Thank you to all of our panelists for sharing your expertise with us. Thank you for your participation again, and please leave your browser open as action item lists will pop up. Look for your certificate in the mail later this week, and have a wonderful rest of your day.
Thank you.